I need permission to record.
Hi, good afternoon or good evening, rather.
Hi.
Hello. Hello.
Hello.
How are you doing tonight?
I'm-
Great. Just got some rain here in West Lafayette, unfortunately today, but it's been good other than that, good weather.
Wonderful. So it's also raining in Northern Virginia. So I would say we're dealing with similar issues right now, plus all the pollen and allergies.
So to start off, you want to just tell us a little bit about yourself and your line of work, I guess, and then we can move into our topic more and some more guided questions and tell you a bit more about like our goals, I guess.
Okay, absolutely. So my name is Dana Hines, and I am a doctorally prepared nurse. I've been a nurse for well over 20 years. I began working in HIV back in 2007. At that time, I was serving as the HIV nurse epidemiologist, where I was responsible for monitoring and tracking all the newly reported cases of HIV in the Indianapolis and surrounding areas, so in Marion County and the surrounding donut counties. And during that time, I started noticing the disparities in racial disparities and gender disparities in terms of who was being diagnosed at initial diagnosis with advanced HIV, or what we used to call AIDS. So at that time, it was primarily Black men who had sex with men, Black women. We had just a very small portion of people at that time who were using IV drugs, but it was then that I decided that I wanted to go back and get my PhD because I really wanted to be more involved in looking at structural drivers of the epidemic and trying to figure out ways that we could, reduce transmission from more of a systems level. So as I was completing my PhD, I moved into a different role at the health department, and then I was functioning as the quality program manager. And at that level, I was responsible for monitoring the quality of care across all of our grant recipients. So at the time, we had about 10 or 12 clinics in the area, clinics and community-based organizations that were receiving funding from our program, which was the Ryan White HIV/AIDS Services Program. And it was my job to monitor the provision of care to make sure that they were providing care according to the HIV treatment guidelines. And then also looking for any gaps in, let's say, HIV health outcomes. So where there are certain subsets of the population who were not being virally suppressed, where there are certain subsets of the population that were being lost to care. And then in identifying that information, helping the clinic staff come up with quality improvement projects or interventions to help improve care for those subgroups. So following completion of my PhD, I went into an assistant faculty position at George Washington University. And there I maintain a program of research that focus on HIV prevention and treatment strategies in trans women, specifically trans women of color. And that was also the focus of my dissertation. So I was at GW for 3 years, and during that time, I worked closely with the Center for AIDS Research. I received funding from them to conduct a study examining barriers to PrEP, pre-exposure prophylaxis uptake among Black trans women in DC. So I've worked both on the prevention side, the treatment side, and now I work for the Health Resources Services Administration, also called HRSA, at an agency called the HIV/AIDS Bureau. And there I serve as their senior clinical advisor or their chief nurse consultant. And it's my job, again, to advise on any policy related issues, any HIV treatment related issues for all of the people who receive care through our program. And again, this is the Ryan White HIV/AIDS Services Program. So I work in the Division of Community HIV/AIDS programs, and we fund approximately 350 clinics. And these are direct service providers, and I work with a number of clinics across the country, looking at their systems of care, looking at their healthcare landscape, looking at where the gaps are across the HIV care continuum, and then taking that information back to our team at the federal government, and then making recommendations on what we need to do differently in our program, perhaps to bridge the gap in some of the treatment areas that we see across the healthcare continuum. So that is a snapshot of what I do. And so I'll pause here and let you orient me to the rest of today's podcast.
Yeah, thanks so much. That sounds like really good work that you've done, and like you've spent a long time sort of focused on one goal. And our goal today is sort of to like look closer at some of like the marginalization, I guess, of the transgender community, especially in terms of HIV treatment. And then, yeah, so could you just tell us a bit about how you think like attitudes towards that and social perspectives have changed over the past few years in terms of just recognition for the transgender community as a whole, and then focusing a lot on how we can get them treated, or at least practicing safer behaviors?
Mhm. Okay, well, I guess I'll start with the general societal attitudes towards the trans population or gender diverse communities. And I have to start by telling you, when I was a doctoral student back in, 2010, I went to my then committee, told them that I wanted to do this dissertation focusing on trans women. And the response was, what is a trans woman? And these were doctorally prepared nurses at Indiana University. What is a transgender woman? How many people are transgender? They were asking fundamental questions that any, budding like PhD student should know. But the issue was that at that time, we weren't collecting two-step data collection for gender identity. It was just the typical, binary male female. So if you're not collecting that data from a systems level in the census, then from a structural standpoint, you're already disadvantaged because you don't have a mechanism of collecting that data. So I couldn't answer the question, how many people are transgender? The only thing I had at the time were just estimates that have been done based on some large studies that have been done in metropolitan areas like LA, San Francisco, New York, Atlanta. And I was like, I can't tell you how many people are transgender, but I know that this is an area that has been underserved, and this is an area that needs greater attention. And they were like, well, it's really not enough to just say, not a lot of work has been done in this area. Like, you have to have more, you have to give us more. So at that time, what I knew that they didn't know is that the then Institute of Medicine, which is now the National Academies of Science, what they had convened a committee to examine all of the research that had been done on LGBTQ health across the last 20 years. So they released this landscape study, that groundbreaking study rather, that said, we need to do more for LGBTQ health in this country. And they explicitly stated that more research was needed to understand the unique health and social conditions of transgender individuals, and that funding agencies needed to explicitly provide funding to researchers who were looking at this area. So that was 2010, 2011. Now we fast forward to 2022. At that time, I was the only nursing doctoral student who had approached the topic on transgender health. And now we've seen that this topic has exploded. There's a lot of interest in it across all sectors: academic, healthcare systems, federal agencies. People recognize now that this is a key population, an important population that has been underserved, but that also intersects with a lot of other communities that might be key populations, or populations that might be at high risk. So I would say over the last 10, 12 years, we have had a growing interest in the population, also greater priority in terms of federal funding and just prioritizing the healthcare needs of this community. And then in terms of just what we see happening in workplaces, we see more emphasis now. Diversity, equity, inclusion has always been a thing, but historically that was looked at more from the lens of race and gender, like having more representation of women, right, in the workplace, and not necessarily trans people. But now we're seeing diversity, equity, and inclusion efforts expand more broadly to look at how are we, as an organization, how are we performing in terms of being inclusive and welcoming and affirming to trans people or to, gender diverse communities. So I think we're seeing a shift in that area as well. And then we're also starting to see a shift in terms of like major insurance companies that are providing coverage for hormone therapy and also some gender affirming surgeries. Like in 2014, the Centers of Medicare and Medicaid, they released their letter that they were now going to be covering hormone therapy and also gender confirmation surgeries that were medically necessary. So I would say those are all positive things that are happening. And I think a lot of that too, we have to attribute to the trans community being more visible. Before, you really didn't hear much about trans people taking a seat at the table, being on the forefront of advocating for change for their own communities. And I think we're seeing this uprising that's been long overdue from the community that is coming forth to say, we matter and we need to have a place at the table, and our healthcare needs to be prioritized as well.
So I kind of wanted to touch on like part of like the communication aspect of like reaching this community in regard to HIV. So like a lot of it, that it functions on like prevention and like risk factors and such. Have you had the opportunity to work with like teens that are transgender, or have you noticed any campaigns that focus on teens?
Mm-hmm. So my work primarily has been with adults with HIV and within the trans community, mostly trans women, and not so much youth. But what I know from just being involved with the community and talking to adults, and then looking back retrospectively, some of the things that they said were really beneficial to them was being part of the house walk community. Because the ballroom community provides a sense of family structure, mentoring, and stable housing, because as I'm sure you all know who are on this call today, that a lot of trans youth are rejected by their families and deal with issues like homelessness and abandonment because their families have, turned their backs on them. And as a result of just needing to survive, it's in their survival that they get into spaces that increase their risk for HIV. So the ballroom community, again, it provides the sense of chosen structure, mentoring, stable housing, and also innovative prevention messaging through their performance. And in terms of, what interventions, I can't really speak to any particular campaign, again, because it's not my area, but I think any campaigns that are targeting youth or adolescents really need to integrate, mHealth, smartphone technology, and anything that will allow youth to engage in prevention and treatment and care from their own standards. And, one thing that we noticed from, our perspective as a administrator of grant programs is that we saw an increase in engagement of care and utilization of care for youth with HIV during COVID, largely due to telehealth, because youth teens, they're always on their phones. So they were able to interact with their clinicians from wherever, and there was the need to have to travel and figure out how am I going to get to an appointment, or worry about somebody seeing you go to an HIV clinic, you could do all of that from the comfort of your home or wherever you were, taking your appointment at that time. So I'll pause there because again, the health campaigns, that's really not my area. And again, I have not really worked that closely with you.
And with that being said too, we know that there's like an unmet need for gene affirming treatment, and like that's strongly associated with issues in HIV treatment. So how do you suggest that doctors manage the increased risk of HIV when they're denied hormone treatments or surgery?
Well, a couple of things. One, I think we have to reframe our thinking, and we need a paradigm shift in terms of like the medical model. So what that would look like is the recognition that hormones are medically necessary, period. Like, not a question mark, hormones are medically necessary. And that understanding must be the focus of any treatment framework involving gender diverse communities. I mean, trans individuals will forego medically necessary treatments for HIV and many other health conditions if they feel like it will interfere with their transition, whether that's hormones or surgical transition, social transition, because not every trans person desires to transition surgically. So anything that they feel like will interfere with whatever transitioning means to them, they will avoid that. And so as a result, if they are denied access to hormones, which are pretty, that's pretty common that most people want that. If they're denied hormones and not treated in a way that they perceive to be affirming and inclusive, most will not engage in healthcare of any sort. And then, of course, that becomes problematic for HIV prevention because you're not able to provide education on prevention, or you're not able to provide access to something like PrEP for prevention because you've missed that opportunity to connect with that individual because you didn't recognize that hormones were medically necessary, or you didn't recognize the importance of using, someone's pronouns that they using their pronouns that they identify with. So those are sometimes like you only have one shot to get it right. And I'm not saying that it's not okay to make mistakes, because I feel like a lot of clinicians are really eager to learn and want to do a good job. But I think recognizing when somebody makes a mistake, apologizing and moving on, that's not the same as just this blatant disregard. Like, there used to be this thinking that, well, we're going to withhold your hormone therapy from you if you don't come in for your visit. Well, that's not an effective way to, communicate and to engage in prevention or treatment for anybody, especially for trans communities. So withholding hormones is not effective. And again, just recognizing the medical necessity of those, I think, is critical. And that has to be foundational to the treatment framework. And I think you had another part of that question that I didn't answer, Janaya. So if you just, if there was something that I did not touch on, just like restate your question, please.
No, that was like pretty much the question. You answered all of it.
Okay, great.
All right, so we know that legislation supporting trans individuals is catching up around the United States, and private insurance systems make it harder to have overarching framework for the over 1 million trans individuals in the United States. So when it comes to insurance, whether that be private or public, what do you think doctors can do to advocate for their patients? And have you ever been successful in appealing insurance coverage decisions in the past?
So I will take the last part of that question first. So I am not directly responsible for approving insurance claims of any sort, but what I am responsible for, and we actually just went through a series of this conversation within my bureau. There was always this question around, and let me clarify. So the program that I work for, we administer the Ryan White HIV/AIDS Services Program, and that grant fund is used to pay for the care and treatment of people with HIV. Our money has to be used as payer of last resort, which means if there's another insurance that has to be billed first. And if there are situations where there is another insurance, but that insurance doesn't cover it, then we become the payer that kind of steps in and fills in that gap. So there used to be this misunderstanding across our bureau, the HIV/AIDS Bureau, that hormones could not be used to pay, that Ryan White funds could not be used to pay for hormones. And we started getting inquiries from a lot of different grant recipients, one being in Los Angeles. And they have a large community of trans patients. But I'm not really sure where that misunderstanding came from, because we also have another program called our Ryan White Part B program, which is our AIDS drug assistance program that has all of the HIV medications on there, including hormones and things like that. So some of it was just educating people within our bureau and across our programs that this was quote an allowable cost, and that it is medically necessary. And so because there was so much confusion around what was allowable versus not allowable, we released a program letter, which we call a Dear Colleague letter, back in December, outlining how our money could be used, how our grant funds could be used to pay for and support gender affirming care. So in terms of the approval, denial of claims or whatever, my role in the HIV/AIDS Bureau is to say, what is medically necessary, and what does the HIV treatment guidelines say about this particular, treatment. So we will pay for hormones, but we do not pay for surgeries. And a lot of public funded insurance companies do not pay for surgeries. Now, I think I had mentioned earlier, since 2014, Medicare has provided coverage for hormones as well as gender reassignment surgery, but it has to be medically necessary. And some private insurances will also pay for that. But the issue is that when we're talking about trans individuals from key populations, so populations that have historically been marginalized and underserved, we also have to consider that many of those individuals are also dealing with poverty. They're unemployed or underemployed. They're not really earning a living wage. So many of them don't even have the private insurance policies that cover all of those things. So there's this economic disparity that's embedded within that. So in terms of what clinicians can do, and social workers, and just public health practitioners, and we see a lot of this lately, is just really sticking with the evidence and the data. So for example, there had historically been this push to do conversion therapy, and SAMHSA, the Substance Abuse Mental Health Agency, they're in the process of releasing an updated statement on how conversion therapy is harmful, and it's not evidence-based. So it's not based in the science, and there's no evidence to show that something like that is even effective. So sticking to the facts, looking at the research, refuting the misinformation and the disinformation that's out there, those are some of the basic ways that clinicians can help advocate for some policy changes, because a lot of the policies, the existing policies that we have in place, are not really founded on science. It's really founded on somebody's personal opinion or their religious beliefs or their personal convictions. And we see those things play out in Washington all the time in the policies and the laws that are even put forth for consideration. So does that help you answer your question at all?
Yeah, you answered it perfectly. Thank you so much.
All right, you're welcome.
Understanding the patient and being empathetic towards their involvement in the decision-making process, like that's a major part of the patient-centered care. What about power dynamics relating to patient-centered care versus provider-centered care is most difficult when communicating with the patients? And going off of that a little bit, like what do you do when a patient does not know what questions to ask you or feels unsure?
Yeah, those are great questions. Well, sometimes you have patients that aren't sure, and you have providers who are inexperienced and they don't know. I published a paper in 2019 called They Just Don't Get Me. It's a qualitative analysis of trans women's experiences in the healthcare setting. And in doing the background preparation for that and looking at the existing literature at the time, less than 5% of medical school curriculum even talks about LGBTQ populations, and that was collectively. And then when you looked at schools of nursing, it was like 2.5% of the curriculum addressed anything remotely related to LGBTQ health. So again, from the beginning, from the outset, we have this disparity in terms of what is being taught in schools. So you have clinicians who are graduating without ever having encountered a trans individual, someone who, is non-binary, and they encounter them for the first time in clinical practice, and they don't really know what to do. By comparison, you might have a trans patient who is seeking care and they already have this internalized stigma and homophobia, and they're anticipating that they're going to be mistreated in the healthcare space because that is typically what happens. They are stigmatized, they're misgendered, sometimes they are met with violent acts in healthcare settings. So it can be a very delicate dance. So I think the first thing for clinicians is to just be open and honest. I was, talking to a trans woman, and she was recalling her experience with someone. And she said, the doctor came in and said, I have to be honest with you. I've never had the opportunity to take care of a transgender patient, but I want to learn and we can learn together. So I think acknowledging that you don't know and being open to learning together with your patient is one way that you can shift the power dynamic. Because otherwise, like in our Westernized culture of medicine, it's like the doctor knows best, and the doctor or the nurse practitioner is supposed to tell their patient what to do. But really, it's like we are our own best advocates and we know our bodies better than anyone. And then when we're talking about trans individuals, just again being affirming, introducing oneself pronouns. So going in and say, hi, my name is Dana. I'm going to be your nurse today. My pronouns are she and her. What pronouns do you use? Something as simple as that shows awareness. Like it shows that one is aware that there are people who don't identify with the typical, male, female binary. And so that alone is enough to just allow this person to feel comfortable and say, oh, okay, so I feel safe now that I can actually say my pronouns are. And then that opens up a different kind of conversation. And then in terms of like the history and physical, when, you're going in, you don't want to just jump right into really personal questions. You have to slow walk your way through it. So some clinicians in the past have had a tendency to just go directly to very personal questions and automatically assuming that, a trans person is promiscuous or that they are doing drugs and all of this stuff. So maybe like if you have a patient for the first time, that first conversation is just going to be really conversational. Just tell me about yourself. Like, what do you like to do? What are your hobbies? What does your support system look like? And then as time goes on, you can start building up a little bit of trust and asking different types of questions. or if it is a situation where you really need some information. Let's say there's somebody who is presenting with symptoms of an STI. Rather than approach that conversation in a judgmental and kind of presumptive way, you might want to say things like, tell me about your sex partners. Do you have sex with men, women, or both? And does your girlfriend have a penis? So things like that, to let that person know, I recognize that people have different sexual preferences. And also, just if a body part is there, you need to check it. Some trans women, if they have not surgically transitioned, they may feel very insecure and vulnerable about having that extra part of their body examined. And sometimes they don't even want to refer to it as a penis. So they might call it something else. So figuring out like what the language is that works for them without being offensive, I think it's also a great way. And I know I've talked a lot about trans women, but trans men, especially as it relates to cervical cancer, they often will present with late stage diagnosis of cervical cancer because of those same reasons. They don't want to have that part of their body examined. But part of it is because we have sexualized the medical encounter so much. And instead of doing that and like putting a gender to a procedure, reframing our thinking and our approach to just having a body inventory. And again, the messaging, if you have it, we need to check it. And asking people, what is it? What do you refer to as part of your body as? Like, what's comfortable for you? So taking those approaches that are just very neutral, open, and expressing a willingness to learn and acknowledging if you don't know, I think are all great ways to really shift the power dynamic and really show interest and cultural humility towards this population.
All right, well, those are all the questions that we actually have for you today, but thank you so much for
My
doing
pleasure.
this with us. It was a wonderful experience to get to learn more about patient-centered care in the trans community, and the work you do is really amazing and it's changing lives for sure. So thank you for your contribution.
Well, thank you. And this was fun. So good luck with your assignment, and I wish you all a great evening.
Thank you so much.
Thanks.
Thanks so much for
you.
talking to us. Have a good night.
Bye-bye. You too. Bye.